All right, very good. We have a bunch of questions that have come in. We'll ask our last two speakers to join us via Zoom. Hello, everyone. Bruce and Alexis, the great presentations. Thank you very much for being here. We have a number of questions. I think I'll start with Bruce. There's a question about making the choice in PSA between 17 and 23, maybe even 12, 23. I mean, can you have any advice for the audience about making that choice in PSA?
Thanks, Jack. It's one of the big things that we see every day. So I think, different components of disease. So in terms of the psoriasis, both 12, 23, but particularly the P19, IL-23 inhibitors and IL-17 inhibitors are very good for psoriasis. So it then depends on what sort of other aspects. So if you've got spondylitis, the 23 inhibitors and ustekinumab is kind of not really been shown to be effective in spondylitis. But if the patient has other conditions such as inflammatory bowel disease, well, then you wouldn't want to use an IL-17 inhibitor. So it's a kind of mixture of the two. It's what's the main part of the disease they've got, and also what are the other components of their kind of comorbidity. And then what we do is when we had a shared care clinic, and you've got someone who's got a difficult skin and joints, then if you're making the choice, it's always good to ask them what they think is the worst part of the condition for them.
Yeah. Artie, Alexis, you have an opinion on that?
Yeah, I think it is all about if you look at the GRAPPA treatment guidelines figure, thinking about what are the different features that the patient has and selecting based on their features and what's most severe or what's most important to the patient too.
Okay. Let's go to the microphone and take a question there.
I have a question for both of you, but it's more related to cytokines. So I'm a clinical rheumatologist, but since I graduated, we have 5 different NIT2 cells, right? There is the follicular cells, now there is another one, and now the dendritic cells get things from the B cells, something called trogocytosis or something, and it's like different types of same cell has now BCR and TCR in diabetes. Maybe now disease, we just don't know. So my question to you is, when we analyze a patient just by domains and we see an enthesopathy who hurts is different from an enthesopathy who build a whole new bone, I predict the milieu of cytokines in these patients are different. So we're trying to do target therapy that is very like precision medicine, but we're putting all these people together, and not enthesopathies are created equal in terms of cytokines. We can see that cannot be the same cytokine. Same thing with other domains. So what's your intake on that?
So I'm happy to step in here if you like, Jack. I mean, that's been what I've been trying to figure out for a long time. I think, when you've got kind of a lot of destruction, then TNF's really destructive. And if you've got new bone formation, that's where IL-17 probably has a role, does cause some bone destruction, also new bone formation. And both cytokines cause inflammation. And then when you've got both together, you're in real trouble because they have this real strong synergy. So I think enthesitis is really hard to study in actual, the actual lesion itself is really impossible to study. So people have been looking at it in mice or in healthy enthesitis and stimulating cells. And they see there's a lot of different cells there, which is similar to the cells we see in the joint. So an inflammatory enthesitis, that's probably the reasons why they do respond well to most of the therapies like the biologics we have, because those cells are kind of similar to the ones in the joint.
Artie, you reviewed this topic last year, and we have a question. Is there any particular therapy that you want to use most with dactylitis?
No, and I think, the other part, and as a follow-up to the last question as well, there's also the intangibles that's hard to us to put something to. We talked a little bit as we're doing the GRAPPA recommendations. Should we give preeminence to factors like experience, clinician experience, patient experience is very important, let alone other things as cost and all. I think when we look at, though, just in a domain, we say, what mechanisms of action have been shown to have a positive effect in that domain? And yet, as you're saying, we see patients don't respond to TNF. Their enthesitis doesn't get better necessarily. And I think we're learning those endotypes of people who either have a great response to one mechanism or no response to one mechanism. And that's telling us something about the immunopathophysiciology in that person. I think the immunopathophysiciology, as I said, it's like a murder mystery. If you know the answer, you can work backwards and figure out who's involved. It's getting it forwards that's the tricky part.
So we have a number of questions about.
Can I say-
Yes, go ahead, Bruce.
It is really tricky because there are no biomarkers, but actually just at the moment we're doing a study in the UK called we're optimized, where we're just starting to treat patients randomly with either IL-17 inhibitors or TNF inhibitor, and then we're looking to see if we can get a blood marker to see if we can predict who responds to which drug, but we'll have to wait for at least 2 years. So I'll tell you in 2 years. Thanks.
Oh, all right. Well, that would be great. We'll put that on the calendar. The common question that keeps coming up in this session is I frequently use Otezla and add it to either methotrexate, but usually I add it to a biologic. Am I right in doing so?
Well, yeah, and we'll ask Alexis to chime in on the Corvitas showed that that's actually very common, and I think it's probably the most common combination and one that people definitely are using. Totally makes sense from the standpoint where most people, I think, use it, where you start something else and you still have residual disease activity. Start a TNF inhibitor, still have residual disease activity, add in the apremilast, and I think people were comfortable with it because of the safety considerations, which, as we spoke of earlier, that's been the real bugaboo with combined therapies is safety. But Alexis, you've had in Corvitas that they do this a lot.
Yeah, exactly. I think we were thinking we would find, 20 cases or so. We had found 90. So there was a lot of people doing this. And I think sometimes what you realize is you can get control of the joint disease with one medicine, but not the skin disease or vice versa. And that's where this can sometimes help too, is that combination. Obviously still off label. And I think the biggest problem is the expense in trying to get them both covered. So I hope at some point this will be a better option that we can do more often, because I think it, like you said, from a safety perspective, it seems pretty reasonable. It still is like combining any other therapies, and I have had one patient hospitalized for cellulitis on that, but it seems like overall it's fairly safe combination therapy.
So Alexis, I want to ask you about real world data, and how do you overcome the hurdle of variable data collection from the many sources you're going to draw from? Not everybody's going to do the CDI or the RAPID-3 or even collect the same safety variables.
So I think that's as long as you're collecting stuff in the same way in one data set that you're analyzing, the fact that someone else in a different cohort study is collecting something different, I think is less problematic. It's really problematic when in one study that's happening, and the place where you see that is in EMR. So people collect lots of different data, and so we have to be really cautious and conscious of that particular problem with EMR data. In longitudinal cohort studies, however, if you have different outcomes, like let's say the CDI and the DAPSA, let's say. So you have two different studies looking at similar outcomes, but usually you see parallel things then. So, and that's what we're looking for, is at least parallel results, maybe not identical results, but that's okay. So I think that problem within one study, but not as much of a problem between studies.
Can I just go one step further? When I was on the FDA advisory panel on the COX-2 inhibitors, one of the big issues was registry data and whatnot. And Milton Packer got up and said, registry data is great at hypothesis generation, not necessarily proving any point. Do you think that we can then say the same about RWE or RWD?
Well, I think what you're looking for is consistency across studies. So no one study is going to be the silver bullet or be, the magic study that's going to give you the right answer. Actually, we kind of demonstrated this purposefully recently, that there's all these studies looking at psoriasis to PSA and the impact of biologics on development of PSA, and they were finding protective effects. And we showed in a different data set that it was suggesting that biologics were associated with more psoriatic arthritis. But it's because of the differences in data sets, and I think that makes us take pause and say, why are we seeing different results? On the other hand, if you're seeing similar results that are very consistent, so let's say association with cardiovascular disease and biologics, that in general you see improvement with therapy, I think that's telling us there's probably something there. So it's not like one study can give you the final answer, but we want to see multiple studies in different data sources showing similar things.
Okay, we have a question at the microphone, sir.
Is there a difference in the endothelial production of IL-17 between psoriatic arthritis and ankylosing spondylitis?
Okay, I'll go for that because, look, it's a great question, but it's one of the real problems because it's really hard to find the lesion in both actually the spine and actually the peripheral enthesis. So there's been some debate, is the enthesial inflammation different in spondylitis? Because the IL-23 inhibitors don't work so well in spondylitis, and we think that's really an important kind of cause of symptoms. Dennis McGonigal, he's the kind of guy who studies enthesitis mainly. He actually gets enthesial cells from the actual spine, from a healthy spine, and then stimulates them. And he thinks there are some cells there that respond to IL-23, but other cells that don't, which may be why treating the spine with IL-23 inhibitors may not give such great results. But he actually, when he first started his research, he actually tried biopsying peripheral enthesitis, and I think he reported about 3 patients. And then it stopped because it's really almost impossible to get those tissue without really huge amount of trauma. So it's a really tough question to answer from a research perspective. And that's where we have to kind of do the studies. So we see that peripheral enthesitis responds to IL-23 and IL-17 and TNF. And we see spinal disease, which we think enthesitis might be an important part of that, doesn't do so well with 23 inhibitors and probably 12-23 inhibitors. So there is probably a difference, but we just don't know why.
Yeah, Bruce, let me ask you as a follow-up to that. I think you're alluding to a very interesting point, as maybe not all entheses are the same. Would you expect necessarily some particularly weight-bearing entheses, like the Achilles, to be different than you might see in a less weight-bearing entheses, like the lateral epicondyle?
Yeah, I think when you look at the, when you look at some of Dennis McGonigal's really great pictures of the enthesial organ, often they'll all be based around the Achilles, which is a very complex tendon. It has huge amounts of weight-bearing load going through it. So it's got cartilage, it's got a lot of other things in there to kind of spread the load. Whereas when you look at the entheses in the spine, I mean, they're not as heavily weight-bearing. There's more of them. It's much more broadly spread. So the load is going through a much wider thing. So you don't have such a complex organ, so you probably will show differences.
Artie, with regard to the 2021 draft, methotrexate is not going to be recommended for uveitis?
Well, a lot of things generated a lot of intense discussion in the GRAPPA recommendations, including that one, and there's very, very little data. Some people felt very strongly that methotrexate was used the most commonly of anything for uveitis, but there's an incredibly small amount of data. There's a head-to-head study of mycophenolate versus methotrexate, which showed that they worked pretty similarly, but really very, very little other data on uveitis. So I think it will be in there, but certainly is not going to be strongly recommended because there is the absence of data, and there are data for other mechanisms. So having a drug FDA approved or approved by EMA probably puts you in the guidelines, but the case in point might be, well, not always, but case in point might be abatacept. It's in the guidelines for PSA. Where does it fall? How do you use it? Just speaking for the GRAPPA process, we tried hard not to do regulatory approval because it's international, and of course there are different rules in different countries, many different approvals or approvals at different stages for particularly for the newer medications. So we really tried to stay away from that and just go with the evidence.
Mm-hmm. There's questions about is psoriasis preclinical psoriatic arthritis? Anyone want to tackle that?
I'll jump in on that. Actually, I know Bruce thinks about this a lot too. So we think about it as, it's the single strongest risk factor for psoriatic arthritis. So if some proportion of those patients are likely to develop PSA. So I think we're still thinking about it as a risk enhancing factor. So there's a lot to learn though, because some people do develop them right around the same time. So it's not a perfect biomarker because, if it's happening right as the joint stuff is happening, or even after in that 10% of people, it's not ideal. But certainly we don't know that it most often precedes the psoriatic arthritis.
I think from a biological perspective, obviously there's strong linkage, but there's also things which then will kind of, as Alex has said, as a precondition, and then things happen. If you've got HLA-B27, Oliver Fitzgerald showed really nice work to show that those patients often get psoriasis and psoriatic arthritis roughly around the same time, and they're the ones who get bilateral sacroiliitis as well. So maybe they're just sort of like X-bar, whereas CW6, which is a really strong genetic indicator for psoriasis, is not that strongly associated with psoriatic arthritis. So there are other HLA-B and C molecules which predispose you to getting psoriasis, psoriatic arthritis. And then you throw in being overweight. And if you've got sort of significant prolonged obesity, you're more likely to get peripheral psoriatic arthritis, but probably not spondylitis. So you've got those kind of predisposing things. Then you've got the types of psoriasis, the scalp, the nails, sort of genital psoriasis, all drive or have a higher rate of generating psoriatic arthritis. And then you've got your kind of other things like the weight and the things like that. And really nice work from Neil McHugh's group in the UK have shown that actually following people over time, if the weight actually goes down, their rate of generating psoriatic arthritis goes down as well. So it's not just a sort of it sounds like a more functional relationship rather than being a kind of just a sort of a relation to getting it. Yeah.
Artie, you really did a nice explanation of the process by which you grade the evidence and grade and sort and whatnot. But in the end, you look at all the ACR guidelines that have been published, it's still pretty much all conditional recommendations and low evidence. So are we just tricking this thing up to make it sound like it's really good when in fact it's not so good?
That's, I think, a great philosophical debate about should you even have them unless you have something that's so strong that you can create an actual guideline. How do you treat people in alcohol withdrawal with the CWAL protocol? It tells you, because there's data that says you should do this and you should do this, or perioperative anticoagulation. Again, they just follow algorithms. In fact, doctors don't even do those kind of things in the hospital anymore. They're driven by the pharmacist-operated algorithms. And I think it shows how in rheumatology we're so far from that because we lack the precision medicine. As Dr. Choi was talking about earlier, a lot of it things of interest, but we still lack the ability to choose one mechanism over another. And I think that's really what you see for the guidelines. So I think they give us a menu of choices from which we can pick. And I think as good as we can do now is to say what domains are the most impacted for that patient who's in front of us. If they don't care about the skin, then we pick one way. If they care tremendously about the skin, we go in a different direction and then factor in the others.
The one good thing about that, to me, in my mind, stands out about the GRAPPA treatment guidelines is that they have great teaching value, and I think the great teaching value is because your treatments are aligned along the domains, which we clearly understand. If you look at, the teaching value of EULAR guidelines in RA or ACR guidelines in RA, they're all over the place and they get confused and they sometimes can, but at least the GRAPPA guidelines, they seem to parallel the way we actually have to approach the patient, which I think is inherently smart.
I agree, and I think that's the easiest way to teach about treating psoriatic arthritis is through the GRAPPA guidelines. I think the other nice thing about creating a guideline like this is it shows you the vast amount of studies that we need to conduct yet, and the need for these comparative effectiveness trials and in personalized medicine embedded within that. So I think it shows us all the things we have to do in the future now.
So there are a few questions about what to do when you're not doing so well, when response to treatment wanes, or you're dealing with what we talked about in RA earlier today, difficult to treat disease. Is that going to be addressed by guidelines? Is that going to be addressed biologically? Is that going to be addressed by real world evidence? Who wants to weigh in on what to do when you're not doing so well in PSA?
So I think one of the things that I was trying to do is take a step back and say, what are all the factors around this patient that are not allowing this patient to respond well, or what else could be getting in the way of response? So that might be depression, that might be obesity, that might be, not having done any physical activity for a long time, and so they have poor mobility and poor function, and we could do better on those things. And sometimes getting that aligned as well as thinking about the therapy is important. And that's also where combination therapy can be helpful too. So, but if they're really not doing well, that's where I step back and say, okay, before we switch therapies, is it the therapy that's the problem, or is it some of these other things that might be problematic?
Another thing, I think Artie was mentioning this a meeting quite a long time ago. I think we can learn something from our gastroenterology colleagues, because now that we measure therapeutic drug levels, particularly when you're getting secondary failure to a TNF inhibitor and you're using something like adalimumab or etanercept, which you can measure the levels, because they can really give you an indication: is this secondary? Have they got drugs, anti-drug antibodies, which means they'll probably do okay. Maybe if they've failed one TNF, they could have another TNF, and that really sometimes gives you a really strong indication of what's going on. If they have very high levels of drug, then maybe you're looking for other, as Alex is saying, there may be other issues, like mood and things like that. Alternatively, if they're really not doing well on a drug, then maybe mechanisms have switched a bit, and you might have to use a different mode of action drug. But I think it's something that all gastroenterologists everywhere in the world measure drug levels all the time, and I think rheumatologists can learn something from them.
I think one of the other cool things that gastroenterologists are going to maybe be doing soon is that they had the first trial of combination biologic therapy. So there was a trial comparing guselkumab versus golimumab versus the combination of the two. I could be wrong about one of those two arms, but they had combination of the two versus one of the other ones. And the combination won, and it wasn't significantly, there weren't significantly more adverse events. So I think these are things that we might be thinking about in the future: is how do we combine our therapies in ways that don't significantly increase adverse events, but might improve disease activity as well.
I think just one other fact is that it's probably been discussed in the rheumatoid arthritis section, which unfortunately I've been traveling today. I haven't been able to hear it. But in our RA patients, we're seeing a lot of patients who have pain syndromes, pain sensitivity, fibromyalgia. And as a rheumatologist, it's incredibly hard to tell if they've got active arthritis or not. So we're using a lot of ultrasound to actually see if they've got active joint disease. And I think we are now finding that in psoriatic arthritis, there's more of that than we thought there was as well. So that's also another thing to be aware of. Has the patient got a kind of developed kind of a pain syndrome in parallel to their joints? And because if you just on the more biologics or whatever, it's actually the wrong therapy, and that's actually a very important thing to think of, and it's very hard to tell sometimes. So what I do is the enthesitis is really the enthesitis as a clinical assessment is a bit vague. You just feel pressure where the tendon joins the bone on the enthesis. But remember, when they've got a pain syndrome, a lot of them will have tenderness everywhere. When they've got enthesitis, they're mainly tender on the enthesis. So that's a sort of simple rule of thumb that I use in the clinic sometimes. If it's joints, well, then imaging can help. Imaging enthesitis is a challenge in normal everyday practice.
Yeah, so 3+ transducer pain is code words for baby fibromyalgia. Okay. And Bruce, it's good you brought that up, because we did actually talk about that and mention that this morning. And there was also a question from the audience about what is the role of ultrasound in the management of PSA? Let me just poll the audience. How many of you have ultrasound machines and use them in your practice? Raise your hand. It's 10% maybe. So from our three panelists, is there an important role for ultrasound in the clinic beyond your clinical skills?
I think there is, particularly I think is in the cases, as Bruce was alluding to, where it's not quite clear. Patients who are difficult to examine, the obese patients with limited mobility anyway, are very difficult to examine, and we'll send them to one of our ultrasonographers, and I'm surprised. And some people, you'd bet that they would not have had inflammation, and they do. And of course, you go in one direction, and then in other people, you maybe said, well, I think it's maybe it's inflamed, and it ends up it's not, and you would go in a different direction. But I think it's great, and the patients all love being ultrasounded. They love looking at the pictures because, and as someone was saying, as Caleb was saying earlier, patients like tests. They like results because it's a result, and they get to see it there. It's much easier. It's much more believable than you telling them they don't need more Enbrel. They need Cymbalta.
In terms of
graded aerobic exercise. Yeah, I mean, yeah.
Knowing the problem that we have with psoriasis and alcohol use, and that the methotrexate warnings about liver comes from patients with psoriasis and alcohol use. The question nonetheless is there an amount of alcohol consumption that you'll allow in your PSA patients? Or is it best not to even talk about it? Alexis?
Well, I think there's a couple tricky things. So one is I use methotrexate. I maybe don't use as much methotrexate as I would in my RA patients because you have a lot of obese patients with diabetes, and those are the patients who are at most risk for liver disease. They often have fatty liver disease. So you start the methotrexate, you see the LFTs bump. So I think we end up using a lot less. I talk to them about the increased risk for liver disease in patients with psoriasis and psoriatic arthritis. And then I tell them there's no known safe amount of alcohol. Probably 1 drink a week is fine. I've referenced the RA study with alcohol, but I think it's just not known. I have had a patient who's developed cirrhosis on methotrexate with alcohol. It was probably the alcohol more so than the methotrexate, but there's just no known safe amount.
But there wasn't a paper from, I think actually from the Thin Network, I think up to like 10 or 12 units. After that is really where it takes off. So above that, it's not. Now, of course, you have the male versus female difference. You have body mass index difference and interpersonal differences. But I don't think it's zero necessarily. And I think I've always told fellows, if you tell the patient you must absolutely not drink, the patient hears, I must absolutely not tell the doctor what I drink.
Yeah. And just to confirm, I don't tell them 0 drinks is the safest. I say, I don't know what to tell you, but probably some is okay. A lot is not okay. Yeah. But I would stick to as little as you need, as you can.
Can I just say, I think for me, I work really closely with our dermatologists, and they're teaching me a lot about the liver. They really think about it, and I always used to think they were kind of, oh my God, they worry and panic about it. But it's because there's this very, very high incidence of fatty liver in people with psoriatic arthritis. So they do tests for fatty liver. There's blood tests you can do, or you can do a liver fibroscan, and they also can ultrasound the liver. So the ultrasound will tell you if there's fatty liver. The fibroscan will tell you if it's getting stiff, which means it may be heading towards fibrosis and cirrhosis. And really, a lot of it is that rather than the alcohol. But obviously, the alcohol is a cofactor, and so is methotrexate. So if they get a fatty liver with liver stiffness, we don't use methotrexate. We're not kind of think it's going to cause kind of cirrhosis, but it's a risk factor that is maybe drive it. So that's where we go, and we use other drugs. And the data I showed in my talk from the Corona Registry, now the Corivitas, in their really great study where they showed a much higher risk of abnormal liver function tests in PSA compared to RA, it was actually people with previous liver problems, but also weight was a big issue. And I think we kind of tend to think of all these people with psoriasis drink a lot, and it's probably mainly because they got fatty liver.
Marilyn Solsky online asked the question about, she thought she had heard it's okay to use methotrexate if you have NASH. Actually, that comes from the RA guidelines, the 2021 RA guidelines say if you have normal liver function, but you have NASH, you can use methotrexate safely. I don't think that's the case for PSA, where we're talking here about another level of caution. So maybe it's not a good idea in such patients who are maybe more prone to liver problems. We do have a number of questions about, we need as rheumatologists ammunition against insurance companies. Does real-world experience and data help fill some of that gap? Or should we be designing trials like that to help answer some questions that we can be using with insurance? And maybe that's, for instance, getting approval for a drug for a secondary outcome, like enthesitis or dactylitis.
Yeah, I think real-world evidence helps when there's the evidence to support outcomes associated with a therapy. I think also we should be designing more trials to address comparative effectiveness and different outcomes so we can see that. So I think the answer to both that you already posed is yes. I think even using trial data that's available is helpful too when we're talking about insurance companies. The more data you give them, the better in general. But I agree that's a very tough hurdle for us.
Mm-hmm. All right, folks, thank you very much for a wonderful session. I want to thank the audience online and in-house for many, many really good questions. We're going to move on to our next session.